Right, hi everyone online and everyone in person, and welcome to our 10th TIA Centre seminar of the academic year. And today, as I'm sure you're all aware, we've got Dr. Lucy Godson joining us in person, which is a pleasure. Excuse me. So Lucy currently works as a digital pathology AI scientist at the National Pathology Imaging Cooperative, or NPIC. Her work focuses on developing advanced AI tools for better understanding melanoma patient outcomes. Before starting her role at NPIC, Lucy carried out her PhD with the Centre for Doctoral Training for AI in Medical Diagnosis and Care at the University of Leeds. And her research, titled Predicting Melanoma Patient Outcomes Using Digital Pathology, investigated the use of MIL, graph neural networks, and survival analysis to classify whole slide images. And the title of Lucy's talk today is Predicting Melanoma Patient Outcomes Using Digital Pathology. Lucy, thank you very much for joining us.
Thank you. And it's actually really nice to be here in person and get to meet some of you. As Adam said, today I'm going to present my PhD work. I just recently had my Viva in October and have passed. And the title of that work is Predicting Melanoma Patient Outcomes Using Digital Pathology. But before I talk about that, I thought I would talk a bit about where I work now, which is the National Pathology Imaging Cooperative. Some of you might have heard of it, NPIC, others not, so I thought I'd give a bit of a brief overview on what we do there. So the National Pathology Imaging Cooperative was started by Professor Darren Traynor, who's a consultant liver pathologist, but who also has over 20 years experience researching digital pathology. And our kind of slogan or mission is a digital pathology image for every cancer patient by 2028. So the main aim of NPIC is to enable clinical use of digital pathology by helping trusts start deploying digital pathology in hospitals. Because I didn't really think about it much during my PhD, but I guess a lot of us work with whole slide images, but in a lot of hospitals, they don't use those images. They tend to use the microscope and glass slides to actually diagnose cancer. So being able to actually start deploying digital pathology in hospitals is a step towards being able to use AI in hospitals. So as you can see on this little map on the side, we started off digitizing Leeds, the hospitals in Leeds, and then that moved into West Yorkshire and Harrogate, and then York and Hull, and also hospitals in the northeast. And so initially we were actually called the Northern Pathology Imaging Cooperative, but then as you can see, in recent years, we've also created a network for digitizing or created a network for pediatric and bone and soft tissue. And this is really important. There's actually only around 50 pathologists who work on pediatric pathology. So having a network where they can share images, get second opinions is a really important thing to do. But also within NPIC, we have what kind of our research themes. So as I mentioned, the first thing is deployment, and that consists of a team of biomedical scientists, technical operations, systems admins who go out into the hospitals and help them start using digital pathology, help them install their scanners, and then look at their pathology workflow and how it will fit in. We also have a research and that's kind of where I sit. So I work on an AI research team with 3 other AI research scientists, but we also have pathologists and project managers who are working on different projects. So recently we published a really interesting paper on the public evidence for digital pathology AI products out there, which is kind of interesting. And we also have a pathologist who's working with Genomics England at the minute on the 100,000 Genomes project. So out of those patients, there's 18,000 patients who have cancer, and we're helping to digitize their pathology images. So that could be a really useful data set. We also have something called the AI Forge. So where we work, we're situated in St. James's Hospital in this tiny office. And when you go up to the attic, we actually have 12 scanners from 9 different vendors, which is a really useful tool to be able to see if there's potential variation between how the images are scanned. And then the third theme is knowledge and skills. So this is looking at trying to help trained pathologists and come up with guidelines for people who are using digital pathology, but also spending time talking to the patient pool and public and letting them know what is happening with digital pathology. But that's kind of interesting in itself, because I think a lot of patients assume we're already using digital pathology, so they're quite shocked to learn that we're not doing that already, because they're expecting us to be using AI soon. And then the final theme is the Quality Coordination Center. So these are a team who are looking at QC. So they're looking at things like I mentioned, scanner variation, but also they recently did work worldwide looking at staining variation. So looking at labs across the world and what the variation in H&E staining is. So last week I learned that in France, they actually put saffron in the H&E stains, which is something I didn't know. So as you can imagine, there's a lot of variation in the staining, which downstream could affect AI. And just to give you a bit of an overview of the scale of MPIC. So currently we're aiming to help digitize around over 30 hospitals across the UK. This will eventually generate 4 million images per year and 5 petabytes of data. So we're at a world leading scale, and it's a really exciting place to work. But yeah, I just thought I'd let you guys know what we're doing there over in Leeds. But now I'll actually tell you about my research. So as I mentioned, predicting melanoma patient outcomes using digital pathology. And as you've all probably guessed, my research really has focused on the past few years on melanoma. So melanoma is the most aggressive form of skin cancer and also the 5th most common cancer in the UK. And while immunotherapy has really revolutionized the treatment of advanced stage patients, there's still a large proportion of patients who don't respond to treatments, and we don't know why. So being able to identify which patients might respond to different treatments, but also potentially find new early stage biomarkers is a really important area of research. So my work followed on from work that was carried out by the Leeds Melanoma Research Group at the University of Leeds, and they focused on looking at transcriptomic data from a group of patients, so around 703 patients. And to do this, they looked at patient tumours and were extracting transcriptomic data using a 0.6 millimeter needle. And then they clustered this transcriptomic data based on the inferred abundance of 27 immune cells. And when they did this, they found 3 distinct immune subgroups. A high immune subgroup where there was high expression of these 27 cells, an intermediate immune subgroup where there was intermediate expression of these 27 cells, and a low immune subgroup where there was low to no expression of these immune cells. And these different immune subgroups also had different underlying pathways, biological pathways, and different levels of potential treatment targets. So it could be really useful in identifying new treatments for patients who aren't responding to immunotherapy. They also had different prognostic outcomes. So the high immune subgroup had significantly better survival compared to the intermediate and low immune subgroup. So these subgroups potentially offer really useful outcomes for patients if we're able to identify patients into these subgroups. But the difficulty with doing this is can be quite costly and time consuming. To work with transcriptomic data, it's not currently used in pathological labs. So what my project looked at is whether we could identify patients into these subgroups, but using their digitized H&E stained images.
Just one question.
Yes.
So how are the immune high and low and intermediate defined?
So it was looking at the transcriptomic data. So they specifically looked at 27 immune cells which were expressed in the tumor. So I think that was based on around 380 genes. And then they gave each they looked at the genes that corresponded to those cells and then looked at the levels of expression of those genes and then kind of inferred the levels of expression of those cells and then gave them a score and then clustered patients based on kind of those expression scores for those 27 cells.
Is this something, a standard way that is followed, or this is related only to this project?
This is just related to this project. It's not, so there are genetic signatures that people have discovered with melanomas, but they're not routinely used for stratifying patients. For stratifying patients, they tend to use the American Joint Committee of Cancer staging groups. But they don't tell you much about kind of treatment response or kind of new biomarkers. So people are trying to come up with new ways to stratify melanoma patients, especially because the staging system doesn't explain like there are a group of patients who are kind of given early stages, but who also end up having metastatic disease. So coming up with new ways to stratify patients in this kind of precision medicine way has become more popular. But yeah, this is just from one kind of paper that we're looking at. So to try and classify patients into these immune subgroups, as everyone in the room is probably aware, it's a difficult task because whole site images are huge. If you printed one out pixel by pixel, it would be the size of a squash court. So that's kind of difficult to process on a single GPU. So what we looked at doing is using a multiple instance learning framework. So when I was doing this work, there was a lot of multiple instance learning methods which were coming out. And they're not exactly multiple instance learning. They have relaxed a few assumptions, but I wanted to see which of these kind of aggregation strategies would be the best for my task. But as well as looking at different types of mill model, we also wanted to see which image resolution would be the best for our task. So we looked at different image resolutions, and we also wanted to look at different feature extraction methods. At the time I was doing this work, there wasn't all the foundation models that are currently out there. So I haven't been able to play around much with those, but it'd be interesting to see kind of what the results would be now. But I'll show you the results I got at the time. So yes, as I mentioned, we looked at 5 different resolutions going from 40x, which was the most zoomed in with a lot of high resolution cellular detail, to 2.5x, which is very, very zoomed out. And then, as I mentioned, we looked at a few different ResNets. So at the time, this was for the feature extraction. At the time, a lot of people were using these ResNets that were pre-trained with ImageNet, but there was a new model out from Sigar et al., where they looked at pre-training. I guess this was like a precursor to the foundation models. So they pre-trained but without using the transformer model. They pre-trained a ResNet using self-supervised learning on histopathology images. The data set they used, though, it was 400,000 images at different resolutions, and it was from the TCGA data set. But as you can imagine, yeah, there's a lot of foundation models out there to try now. And then the different mill methods we used. So we used a max mill model, which looked at ranking the patch features based on class probability distributions of the slide classes. And then we also looked at 5 other models that all used different sorts of attention mechanisms. because at the time, these were probably the most popular MIL models that people were using in their aggregation step. And then to carry out this work, we looked at 2 different data sets. So I've been really lucky to work with the Leeds Melanoma cohort data set, which was a data set that was established by Julian Newton-Bishop, who was working at the University of Leeds. And this data set, they started collecting data from melanoma patients in the year 2000 and stopped in 2012. So it was over a really long amount of time, and they collected data from over 1,000 patients. But for this work, I just focused on 667 slides from 667 patients because they had the immune ground truth labels that I wanted to look at. And we also replicated our results using the Cancer Genome Atlas dataset, so the TCGA. This was a slightly more heterogeneous dataset, which also included metastatic cases. The TCGA in general for melanoma has quite a lot of later stage cases, but we wanted to include them to see how well models performed on this separate dataset. And initially, when we were running our models, what we found was the attention MIL model using 10x patches produced the best mean AUC when using a tenfold cross-validation of 0.61. And then the TCGA train model generated the best, a gated attention MIL model generated the best AUC of 0.68. While it's better than random, it wasn't particularly great. I mean, it's not something that could be implemented clinically. So what we did was we looked at the confusion matrices, and here we found there was a lot of misclassifications between the high and intermediate subset of immune patients and the low and intermediate subsets of patients. So what we did was we wanted to see if there was still a signal, a difference between the high and the low immune cases. So we kind of simplified the problem and removed the intermediate subset of patients to see if models were still able to identify high and low immune cases. And when we did this, we found that overall, the ResNet, which was pre-trained on pathology images, tended to improve performance. So on these graphs, that's shown by the gray line, and then the different patch resolutions are shown at the bottom with the mean test AUC at the side. And also overall, models that just had an attention mechanism gave the best performance. So we didn't see that much significant difference between the 5 different MIL models that applied attention mechanisms. They were better than using max MIL, but yeah, they seem to give similar performance overall. And then we also found that using 10x patch representations generated the best performance. So there seemed to be a peak with the 10x resolution.
Was there any particular reason why they were doing like best at this level? Because it's predicting the immune clustering or something. So why is it like a 10x? You get a chance to look into some pages, or the pathologists look into them?
Yeah. So I think the reason for that is because it has slightly more context. So when use 40x, it just kind of shows cellular detail. And so what we were finding is like some models would just pick up that there were lymphocytes, but they weren't picking up that there were lymphocytes within the tumor region. So we needed both that there were lymphocytes, but also that it was within the tumor. So it's kind of maybe that added context, which led to better classifications. So we did look at some high attention patches and develop some heat maps using the attention scores from the different MIL models. And so this is a image from the Leeds Melanoma cohort, and these are patches at 40x resolution. And this was a model that predicted the correct class of high immune. And what we found was the high attention patches did include lymphocytes, which is what we wanted to see. But then we also wanted to look at where the model was misclassifying cases. So this is from the TCGA, and it should have been a low immune case. But when we actually looked at the patches, so these dark little circles, the pathologist I was working with, Emily, said they're likely to be lymphocytes. However, they weren't within the tumor region, which is where the ground truth label was generated. So although the model is able to pick up lymphocytes, it's not probably using the context enough to be able to make a correct prediction. The other potential issue is that because the ground truth labels are generated from this 0.6 millimeter biopsy needle, that might not be representative of the whole slide image that we actually gave the models. So it might pick up lymphocytes in certain regions, even though maybe where they got the ground truth label didn't have lymphocytes. So there was kind of this difficulty with noisy labels, which are localized to a small region. And also, we wanted to look into if we could incorporate more contextual information as well, because as I mentioned, it was picking up lymphocytes, but not really the surrounding tissue that we wanted to see, so the tumor tissue. So one of the ways that is quite helpful at adding one of the ways to model context is using graphs, and whole slide images intuitively have a structure that really plays well which is really good for using graphs. So we wanted to do that because, especially with the mill models, because they just take patches as input, you do lose a lot of contextual information as well. So by using graphs where you can connect the patch or node features with edges, you can kind of give more long-range information to the model. So we wanted to also explore using multi-resolution graphs, as this is more similar to how a pathologist looks at images. They don't just look at one patch at a single resolution. So being able to build that into whole slide image representations is something that we wanted to do. And so we spent a bit of time looking at different ways to represent these like multi-level graphs. So we looked at different ways to represent the edges. So we had certain edges to represent going from one resolution to another. And then we started exploring using edge features to represent different directions. So going from 10x to 20x or 20x to 10x. And then finally, we came up with our one hot node graph, which also incorporated one hot nodes to kind of give these resolution aware embeddings. So for each resolution, we had a different one hot node feature representation to kind of give the model information as to where these features come from. And so similar to our previous pipeline, we divided the image up into patches. And then because from our previous experiments, we'd seen that the features from the pathology specific ResNet gave the best results. We used those features for nodes, and then we constructed these multi-level graphs, but also we wanted to compare against just single resolution graphs as well to see how, if this multi-resolution actually led to improved performance. And then to process these graphs, we use a graph neural network with GAT-V2 layers. We also experimented with how to aggregate the final graph features. So we tried using an attention mechanism, but also just using a mean pooling mechanism to see how this affected our model performance. And for this work, we just used the Leeds melanoma cohort to perform our experiments.
There you go. Yeah, so I'm just wondering, so how do you aggregate the features? For example, the top level, you would have a patch size of like much bigger than the bottom level. So when you explore features, as you have to input fixed size into the ResNet. So how did you?
So this is the thing that I think is a bit of a spoiler, but the multi-level graphs didn't perform as well. But because we actually just used all the possible patches from that layer, so there was like 16 times more 40x patches compared to like 10x.
Yeah.
And then we just aggregated those all together. So we didn't use, because I know some researchers have looked into like aggregating different resolutions instead of aggregating all the nodes together. You can look at just aggregating a single resolution.
Because you just have less nodes.
Yes, yeah,
Okay.
yeah. But I think that might be one of the reasons they didn't perform as well as we hoped, because there was this huge imbalance in the nodes for the different resolutions. Yeah.
Okay.
Just wanted to ask, like, when you said you were using multiple instance learning or aggregation, did you do it for getting a slide level representation from the graph or not? Or was it just for predictions?
Just for predictions, yeah. Yeah, that would be something to try as well, I think. Yeah. Oh, cool. So again, we tried to predict or classify the 3 immune subtypes. And what we found was using the graph neural networks with the graph representations did lead to a small improvement in the mean AUC. But again, as you'll notice, it's not a groundbreaking classification AUC. And so again, it was this problem where there was a lot of misclassification between the intermediate and low and the intermediate and high subgroups. But then when we just simplified the problem and looked at the high and low immune subtypes, we found that the graph neural networks with the graph representations tended to outperform the mill models that we previously used for classifying patients into the high and low immune subgroups.
That's a question, sorry.
Yeah.
So you said in general the 10x worked best for just regular MIL.
Yeah.
So how come when you got to multi-resolution, you used 10, 20, 40 instead of say 5, 10, 20?
That's a good question. I think because we did find for some cases 40x did lead to, so there was a strange trend where 10x usually was the best, but then also occasionally 40x performed not as well as 10x, but slightly better. So we thought maybe there was something important with the 40x. But it would have been cool. I think it would have been nice to try a lot of different resolutions, because the other thing that we didn't try was just 10x with 40x, because they were the best. We tried 10x with 20x. But yeah, it would have been interesting to try different resolutions to see how they perform.
So in the GNNs, so those are your multi-resolution GNNs, right?
So the multi-resolution is just the one at the end, the darker one.
I think we discussed it as well, but what I found interesting is that when you use GNNs, the resolution doesn't matter.
Yeah.
So it doesn't affect as much as some of the other methods.
Yeah, I don't do. I think it's because like it's this. Well, this is what I believe, that it's the context thing. So as soon as you so with the other methods, yeah, the 40x seems to be a lot worse. But I'm thinking maybe if you add this graph representation context, it really improves the 40x performance. Yeah, it is weird, but yeah, I'm thinking it must be to do with context.
So yeah, we have a few questions online. So Jack said he'd be interested to see a 10x model and a 40x model. So I think I just spoke about that. And Yuri's asked, did you try to compare your method for immune cell subtyping with simple cell detection and immune cell quantification using e.g. pan-nuc trained?
I haven't, but I think that's like a really good suggestion. For all my PhD, I was just using patch-based features, but I think it'd be really cool to look at that. One thing with melanoma is like the immune cells and the tumor cells can sometimes look quite similar, so it's quite difficult to do the immune cell detection. I think there's currently a challenge called Puma out where they're trying to. Have you seen? Yeah.
Yeah, we're currently doing it.
Oh, yeah.
Yeah, I do notice some tumors are really similar to the lymphocytes.
Yes, yeah.
Yeah, that's a problem for us currently.
Yeah, so it'd be really cool if there was. I haven't tried pan-nuke might be. Yeah, a pan-nuke trained model might be useful to look into. I saw there's a model. I think it's called VIT that's out now as well. That might be cool to try because I think as well it'd be nice to train a model with the patches, but then almost like verify that. By doing some kind of cell detection afterwards to kind of see if it's working. But yeah, that's a really good point. But to continue, we also did look at, again, so these red regions are the top 5% of patches from the attack mechanism. And again, with the high immune cases, there does seem to be lymphocytes in the tumor regions, which is really good. But then we also were having this issue, which again might be to do with the immune labels being generated from a small region. There are these kind of patches which look like they might have lymphocytes in, but again, it might be what we mentioned where lymphocytes and tumor cells do look quite similar. So the model is confusing these, but also the pathologist I worked with was like, this is very, very overly stained. So she found it difficult herself to tell what was happening in this image. And then finally, as I mentioned at the start, one of the really important things about the immune subgroups is they have prognostic associations. So there's differing survival between the high and the low immune subgroup. So what we wanted to look at is whether the classifications from the model, so the high versus low immune, whether they still generated classifications that had differing survival associations. So to do this, we carried out, we used a multivariate Cox proportional hazard model to generate hazard ratios. And interestingly, when we looked at the results from that, the graph models, although some of them did have significant hazard ratios showing that they were stratifying patients with significantly different survival, some of them weren't significant, so this 40x and 10x. And also we found that the transmill model that we previously used, although it didn't have better performance, it seemed to be classifying patients with a higher hazard ratio, which was quite weird. But as we mentioned, this was a simplified data set that didn't include the intermediate patients. So what we wanted to do is then add the intermediate patients back into the test set and see what happened when the model was classifying those as high or low immune cases. And then when we did this, we actually found that the graph models classified those patients into high and immune, but with the highest hazard ratio, which was really interesting, suggesting that it was classifying patients on some kind of signal that might work better on the more heterogeneous patients. And then when we looked back at the transmill model, which had been the best at, which had the highest hazard ratio for just the high and the low immune cases, it actually had a much lower hazard ratio when including the intermediate cases, which suggests it wasn't able to maybe classify those intermediate cases as well based on a prognostic signal. Yeah.
So with your graphs, planar graphs, like they were collecting only a certain region to its neighboring region.
Yes, yeah, the single resolution, yeah. So to summarize, kind of, this was the last part of the immune subtyping work, but we were still struggling to classify this intermediate immune subgroup. And we talked about this during my Viva. It's probably not the best for a classification task, because this intermediate subgroup is very heterogeneous. So potentially using some kind of different method, maybe something that uses regression, or previously there'd been a group that had actually classified the patients into 6 immune subgroups, so maybe breaking this intermediate subset of patients down further might be more helpful in classifying those patients. We also saw that the multi-resolution graphs didn't lead to the best performance. And I think that was probably the reasons that we outlined earlier. Having just an imbalance of nodes might lead to kind of problems. We also discussed in my Viva, because I'd used a feature extractor that was trained on multiple resolutions, would that affect the feature resolutions? Does that add some kind of multi-resolution information into the single resolution graphs? That would be really something interesting to look into. Also, I didn't really look at different types of encodings. I know with some transformer models, they use different positional embeddings that give local context. So it would have been cool to try out different encodings for that, or different types of edge features would have been interesting. But ultimately, following this work, I was interested then in what happens if we just use the images and survival data and try and find our own prognostic subgroups. So that's what I looked into next. As I mentioned a bit earlier, the current staging system that is used for melanoma patients does show wide levels of variance. So I've put at the top there, 20% of all melanoma deaths are from patients who present with early stage disease. So there are some patients who have these thinner tumors that then go on to develop metastases. So it's really important that we try and understand why, and find potentially try and find early stage biomarkers to better understand the progression of disease. And the other interesting thing is Breslow thickness, so the depth of the tumor, that's been the most important predictor of survival for over 50 years. So, but there's so much, a wealth of information in histopathology images. So it's kind of an exciting area of research to potentially try and find if there is something else there. So I've just got some of the clinical features of the Leeds melanoma cohort over here. But for the staging, they actually only use Breslow thickness, so tumor depth, ulceration, which is whether there's been a disruption over the melanoma in the epidermis, and mitotic rate. And I think microsatellite instability is the features, the histopathological features used in staging. So there's still a lot there to discover. They don't even use lymphocytes in TIL classification in the current staging system. We also do have histological subtypes in melanoma, but there's a lot of association with these subtypes with tumor depth, so they don't tend to use those to understand prognosis. So to carry out this work, I continued using my single level graph representations, and also looked at the multi-level graph representations again, and used a graph neural network to process these. But from the graph neural network, we generated unnormalized risk scores. And to update parameters for this network, we used a negative log likelihood version of the Cox proportional hazard model. So it was from this Katzman paper, it's called DeepServe. And with these risk scores, we then ranked them in order, excluded the top 25% and bottom 25%, and then used 100 different thresholds within those risk scores, and looked at, this was within the validation set, and then split the data using these risk scores, and looked at the log rank p-values in the validation set, and picked the threshold that had the lowest p-value, and then used that to dichotomize, or to get our high and low risk strata in the test set. And while doing this work, we explored different aspects of the network. So we looked at different numbers of hidden layers, different types of graph resolution input. We also looked again at this attention mechanism. And we did try and look at 2 versus 3 risk groups. But ultimately, what we found was from this survival graph neural network, we ended up with 2 risk groups that were generated using the 10x features. So again, this 10x number, which achieved a C-index of 0.73 when we used a multivariable Cox proportional hazard model with other clinical factors associated with melanoma death. And then what we wanted to do then was compare to the current clinical features that are used for survival analysis of melanomas. And so in this, this is from the Cox proportional hazard model using the currently used clinical factors, which gives a C-index of 0.71. So then we performed this stepwise regression using backward elimination, which meant that we included in this Cox proportional hazard model the risk groups from our best performing survival model, but also the immune subgroups, which we generated using our graph neural network previously, but then included also the ground truth immune subgroups, the current staging system, and the tumor site, and then other clinical factors. And then what we did was we removed any covariates which weren't significant. And when we did this, we found that the immune subgroups, so the original immune subgroups that we were looking at predicting at the start, were no longer significant. And the immune subgroups generated by one of our graph models did remain significant. So along with the 10x risk groups, they were able to replace those immune subgroups. And also the model with our new risk groups from the 2 different models had a higher C-index compared to when using the clinical features that are usually used for melanoma. So it was a really interesting finding. Although we didn't find that our new risk groups were better than the current staging system, it was interesting to see that they were able to replace the immune subgroups.
Excuse me. So maybe I just missed. What is the training set and what is the testing set here on which you identified those features?
Yes, so we were using tenfold cross-validation. So we were using, I think it was like 80-10-10 splits. So then
it was the same, so it was one cohort, yeah?
Yes, yeah. Well, it was just the Leeds melanoma cohort. So yeah, it would be, that's kind of the next step, I think, to test it on an independent data set. Especially like, because the TCGA, we've got primaries from primary melanoma, so it'd be good to test them on that.
When you say it didn't perform better than the existing staging, you mean in terms of hazard ratio?
And C-index.
What was the C-index for?
So it was 0.71, and then with the new features, 0.73.
So is this index, sorry, just for, is this the test set from each fold of cross-validation?
Yes, yeah.
And you've done it across the whole test set?
Yes, yeah.
Sorry, the combined test set. Okay.
Yeah, so the unseen test set, but yeah, it's from each fold, so together. And then finally, we just wanted to see if we could understand maybe some of the underpinnings behind the low risk and the high risk group. So we looked at some of the clinical factors or the covariates between these groups and tried to see if there was any difference. So in the high risk groups, it tended to be thicker tumors, and also there seemed to be quite a lot more ulcerated tumors. Ulceration is associated with more aggressive tumors. So this would make sense for this risk group. And as you can imagine, the high-risk group also had a lot more of the later stage patients. But there are still some patients who are at early stage who are in this risk group. So it would be really interesting to spend more time understanding why those patients are in this high-risk group. And there's also some differences between histological subtype, but that could also be associated with the tumor thickness. And then we also looked at some of the high attention patches from one of the other models that used an attention mechanism. And I showed the pathologist these patches, and she said it looked like there was a lot of tumor cells compared to supporting tissue. So she said this might relate potentially to the tumor stroma ratio, which is something that's quite underexplored in melanoma. Although we look at things like the genetic underpinnings of the tumor, it's not as looked at. So that was really interesting to hear. But as you mentioned, this was only on one data set. So in order to kind of really validate that, we'd want to look at a large external data set. But yeah, so the main kind of contributions to this work, we developed a pipeline to classify melanoma patients into immune subgroups. We also show that these 10x resolution patches tend to improve performance, potentially because of that balance of cellular and contextual data. We showed that the self-supervised learning feature extractor trained with histopathology images improved performance. Obviously, now there's so many foundation models out there. It'd be really cool to see what the results would be if we used one of those. We also explored different aggregation mechanisms and showed for the MIL models that attention mechanisms improved over the max MIL, but there wasn't much difference between them there. And again, this idea of context from graphs seemed to improve our results as well. And yeah, just at the end, we looked into these potential new imaging biomarkers, which was really interesting. But obviously, there's a lot of future work that could be done, kind of changing the framing of the intermediate subgroup and exploring kind of the new innovations like transformers and foundation models. And yeah, we'd really like to validate our findings on a large data set. But I think that's it from me. Thank you so much, everyone, for listening.
Well, thank you very much, Lucy, for a fantastic talk. I know we've got a couple of questions on the chat online already, but does anyone in person or online want to speak up and ask any questions? I know Yuri's got a couple of questions that have gone unanswered so far already. So Yuri asked, could you share your experience with dealing with significantly overpigmented cases? Were pigmentation rather a noise or MIL? So were there some cases that were not analysable due to very high pigmentation?
So this is something that I didn't look into much because we didn't perform a lot of QC. It was something, though, when we looked at error cases, sometimes they did contain pigmentation. And yeah, it's a unique challenge to melanoma. I've seen in other papers, like when trying to use different kind of off-the-shelf algorithms, people really struggle because of this pigmentation. Because yeah, I don't know if you've seen it. It just looks, yeah, it looks very different. There's like kind of a brown thing over the image. But yeah, I'm not sure. It's difficult. I would be interested if anyone else has found a way to kind of deal with that. But yeah, nothing yet.
It's pretty unique to melanoma then. Well,
yes.
skin in general.
Yeah, it is. Yeah, it's really interesting. They're just like very I feel like people say this about a lot of cancers, but they're really heterogeneous. But yeah, that's just another of the interesting things about them.
No, thank you. And Yuri's also got a second question here that he said, were there immune high melanomas with bad prognosis? Does the composition of immune infiltrate matter?
So overall, they had better prognosis. I haven't actually looked at individual cases, but that would be interesting to look at because there is a thing where with kind of tumours, I think they do sometimes have immune infiltrate there, but they're still not responding to kind of immunotherapy as you would expect. And the composition of the immune infiltrate. So we just looked at the 27 immune cells, but I can imagine it probably does, as I think different immune cells do different things. But it's definitely something to look into. Yeah, that's a really good question.
I just wanted to touch on, like, you had two data sets, right? So did you try, I think you did try training on one and testing on the other for the survival analysis as well, didn't you?
I haven't tried that yet, no, because it's so we have the TCGA data set, but which does have primary cases. So we trained the survival model just using primary melanomas, and the TCGA does have some primary cases. So I think that's the first thing to test. It's again kind of like it's quite different. Even just visually, that data set has, so the Leeds melanoma cohort is like very purples and blues, whereas the TCGA is very dark pink staining. So it'd be interesting to see if it does work on that data set. But yeah, and also I think I was talking to you about it, that the cases for the TCGA also quite, a lot of them are late stage, which is different compared to the LMC. So it would be really cool to see how well it performs on those cases, definitely.
I know you said you've got something like 9 or 10 different scanners. So
Yeah.
are these different scanners? Sorry.
Oh, scanners.
So are these? Is this cohort from multiple scanners, or is it just one scanner? Or
no, this one's from just one scanner, but it would be interesting as well to test that out if you could see if the kind of model transfers from one scanner to a different one.
Has ENPIC produced a data set of the same slide scanner with these 9 scanners for the community?
Not for the community. So that I think they are doing that for Genomics England, and I'm hoping that data might be for public, but it would be really interesting to look at. I know there's is it called PLISM? There's a data set which has different uses different scanners, but yeah, it'd be really interesting to look at that. Yeah.
Yeah, we had a seminar by Dan Gage from Radboud about a year ago and he was using the big melanoma data set. I wonder if that's publicly available from Radboud. That could also help with the size of data used. But
yeah, that would be good to look into.
It's even possible to identify 27 subtypes of immune cells initially.
I don't think so. I think that potentially might be the reason why at the end the immune subgroups from the GNN model stayed significant, because I think they're just a massive simplification of the actual ground truth labels. Potentially they are just classifying TILs within the image rather than actually being able to classify all those 27. Yeah. Yeah, because I think even a pathologist would struggle without extra staining to be able to identify that.
But never say never.
That's true. There is probably some pathologist out there who's looked into it.
I've got a generic question. I really enjoyed the live line you had there, and I think you're a brilliant scientist. Just because we've got PhD students in the room, where do you see the future of computational pathology heading into with the emergence of all of these foundation models and everything coming along? What's your perspective on that?
Oh my gosh. I'm not sure. It's very interesting. I think we were discussing this earlier. Foundation models have been a real game changer, and it's so interesting to see that for certain tasks they perform so well. So I think Jack's on the call, and he was getting really, really good performance when he was testing out different foundation models. but then on other tasks, they don't seem to perform as well. I don't know whether we're going to get to a point where we have like bespoke foundation models for different kind of tissue types. I think that would be quite interesting. Or whether there's just going to be one foundation model to rule them all that's been trained with so many images. Although the thing is, the thing that I found with the foundation models is it's meant, I think we think less about aggregation. I know there's like slide level foundation models, and I think that's really interesting. But yeah, like looking at things like context, because if we go very patch focused, I think that'll be really good for certain tasks. But it would be interesting to see if people also start thinking of different aggregation methods with these, with the foundation models. But yeah, I have no idea. It's such an interesting field to be in. I think, yeah, because even with like the DeepSeek version 1 coming, of which version it came out, does that mean we're all going to start using reinforcement learning now?
Also, like, what progress do you see to the larger scale adoption of these methods? Going into NPIC must have changed your perspective, as you mentioned in the beginning as well. So do you think that there are some practical barriers that need to be overcome?
Yeah, definitely, because I think, yeah, it was so interesting. So firstly, we need to have digital pathology, I guess, in most hospitals. So that's the first step. But then even, I think, with these commercial algorithms and actually having like the NHS purchase them, there's a lot of kind of just logistical issues with, do you send them your data and then do they send you the results back? And kind of a lot thinking about things like, I guess, continual learning, like will they have to get new FDA approval if they retrain their models on different data sets? And also things like, should you send them images to calibrate their models? Like there's a lot of interesting logistical stuff with deploying these algorithms. I do think we will eventually deploy AI in the NHS. But yeah, it would be really, I don't know when though. Yeah.
Well, thank you very much. Does anyone else have any final questions before we finish the seminar? Well, Lucy's going to be around for the next hour or so, aren't you, anyway?
Yeah.
So if anyone does have any questions, then please feel free to come find her. I know Jack's made a couple of comments as well and said that about PLISM, that appears to be both multi-stain and multi-scanner. And aggregation appears less important than the feature extraction, even for more spatially motivated outcomes like prognostics. And he's referenced Peter Nodlinger's paper there. But thank you very much, Lucy, for a really interesting talk. And thank you very much for joining us in person. I really appreciate your time. So, and with that, I suppose we'll call the seminar to a close. Just a final plug. Our next seminar is in 2 weeks' time, where we're joined by Zilong Weng and Dr. Yuri Tolkok from University Hospitals in Cologne. They're going to discuss Grand QC, so that should be interesting for everyone. So hopefully see you there. We've also got another special session at MIUA this year in July 2025, obviously, and it's called Frontiers in Computational Pathology. The full paper deadline for this is the 24th of March. And Buzz has got a question online, I think. The site of skin would be worth looking into with Clark and Breslow vascular network in vicinity of melanoma would be good to see too. Maybe staining for type of TILs.
Yeah, I think that's what we were saying earlier. Like, I'm trying to classify patients based on this these immune subgroups, but yeah, we don't. It's hard to tell what kind of immune cells are actually there with just H&E staining. You've even, yes, yeah, having that information would be really interesting. Because because I think it gives UV versus non-UV might give indication of like mutations as well. Oh.
Maybe ask Buzz to speak.
Buzz, do you want to speak up?
But just a suggestion, Lucy, have a chat with Buzz if you find time. He's got plenty of ideas and he's working in skin. Would be useful for you to connect with.
Yeah, that would be great.
Buzz, are you happy for us to share your contact details with Lucy?
He said good luck.
Brilliant.
Good things.
Brilliant. Well, thank you very much, everyone, and thanks again, Lucy, for giving me time.
Oh no, it's been great. Thanks so much for having me.